Hello, I am Dr. Everton Prospere. I'm a medical attending in the Department of Medicine at SUNY Downstate Health Sciences University. I'm also the director of the Geriatric Medicine Fellowship, and I'm a co-director of the Brooklyn Initiative to develop geriatric education. Today's session, which is a self-learning module, or SLM, is on geriatric syndrome. And this is the first of 3 sessions on geriatric syndrome. So today's session is actually geriatric syndrome 1. I have no significant conflicts of interest or financial disclosures. However, this presentation is supported by a grant from the Health Resources and Services Administration of the United States Department of Health and Human Services. This is a list of some of the commonly used acronyms or abbreviations that is going to be used in this presentation and some of the subsequent self-learning modules. HRSA, GWEP, Bridge, SIAD, 4Ms, Bridget, ADRD, Bridge Gap, ECHO, and SLM. This is a list of the curriculum. This self-learning module is part of a broader curriculum or Bridge self-learning module. The components of that curriculum is the comprehensive geriatric assessment, 2, the wellness and functional ability, 3, interprofessional teams and interprofessional care of older adult, 4, age-friendly healthcare systems, 5, dementia-friendly communities, 6, geriatric syndromes, 1, geriatric syndromes 2, there's also going to be geriatric syndromes 3, 8, culturally and linguistically competent healthcare of older adults, and 9, ageism. This slide represents a snapshot of all the various locations or environments where we can actually find older adults. And it ranges from, critical care setting in a hospital to the patient's residence or even outdoors. This slide summarizes the 4Ms framework or the 4Ms age-friendly healthcare model. The age-friendly healthcare model is an initiative by the John A. Hartford Foundation and the Institute of Healthcare Improvement in partnership with the American Hospital Association and the Catholic Health Association of the United States. The 4Ms framework takes into account what matters to the patient. It also takes into account medications and polypharmacies and potential for adverse outcomes and drug-drug interactions. It takes into account mentation, including depression, dementia, delirium. It also takes into account the patient's mobility and functional status. In the 4Ms framework, the intent is to emphasize that every older adult is entitled to comprehensive geriatric care, and the 4Ms model is one of the best framework under which to ensure that every older adult gets comprehensive, age-friendly care. So the objectives for this session, Geriatric Syndromes 1, is by the end of this presentation, the attendee or the learner should be able to define a geriatric syndrome. The learner should also be able to describe the specific geriatric syndrome of frailty, undernutrition, and obesity. And the learner should also be able to identify the diagnostic and therapeutic approaches to the management of frailty, the management of undernutrition, and the management of obesity. So let's brainstorm for a minute. What is geriatric syndrome, or what is a geriatric syndrome? What's the definition of a geriatric syndrome? So a geriatric syndrome is a group of signs and or symptoms that tends to occur in an older adult at a rate that is more frequent than it occurs in a younger adult. And those signs and or symptoms, they tend to characterize a particular abnormality or a particular condition, such that those signs or symptoms include emotions and or actions that usually form an identifiable pattern. And those abnormalities or those conditions tend to occur more frequently than is likely due to chance alone. So why is this relevant? This is relevant because we practice evidence-based medicine. We practice an evidence-based standard of care. What's the strength of the evidence supporting or guiding our decision-making process? Is the evidence, is the data consistent? Is it patient-centered? Is it reliable? Has it been validated? This is relevant because whatever we do in medicine, our assessments and our intervention should translate into an improvement in quality of life and or life expectancy. Another way of saying that is that our assessments and our interventions, whatever we do, should result in a decrease in morbidity and mortality. And that should be guided by the 4M's framework model. What matters to the patient, aligning our goals and care in accordance with the patient's will and the patient's wishes. It should be aligned with the patient's, taking into consideration the patient's mentation, the patient's mobility, the patient's medications. So whatever we do should impact quality of life and life expectancy. And there's evidence to show also that our intervention will impact the patient's ability to perform activities of daily living, instrumental activities of daily living. And the overarching goal is to promote independent functioning by limiting disabilities and limiting dependency. So this is a list of some of the geriatric syndromes in our curriculum. Today's session is on frailty and nutrition and weight. Other geriatric syndromes include delirium, dementia, dizziness, dysphagia, gait abnormalities, hearing loss, incontinence, specifically urinary incontinence, osteoporosis, pressure ulcers, visual disorders, and hearing loss. So what is frailty? What's the definition of frailty? The word frailty comes from Latin. It has a Latin origin. It comes from the word fragilis, which means fragile. The English version is fragile. If we were to look it up in the dictionary, it would say the condition of being weak and or delicate. But many older adults may be weak or quote unquote delicate. But weak and or delicate does not satisfy the clinical definition of frailty. So what is frailty? Frailty is a clinically recognizable state of increased vulnerability resulting from aging-associated decline in reserve and aging-associated decline in function across multiple physiologic systems in such a way that the body's ability to cope with everyday or acute stressors is compromised. So what does that mean? Frailty is a chronic progressive condition. It's characterized by a gradual cumulative decline in physiologic function. It is characterized by a decrease in the body's ability to compensate or to recover from stressors, or a decrease in the body's physiologic reserve such that the body is unable to compensate or unable to recover from stressors. It's also characterized by a decrease in tolerance to acute illnesses and decrease in tolerance to extremes of temperatures, decrease in tolerance to trauma and medical and or surgical intervention. Frailty is also characterized by an increase in vulnerability to adverse health outcomes. And this includes adverse health outcomes such as the risk of falls, the risk of injury, abrasions, lacerations, fractures, the risk of disability, dependency, increased risk of institutionalization, complications from procedures, and increased risk of death. There are two concepts of frailty, two types of frailty. There's what's termed physical frailty, and there's also index frailty. Physical frailty is also called phenotypic frailty or syndromic frailty. In physical frailty, it is believed to be based on the clinical presentation. So what signs and or symptoms is the patient presenting with? The exact cause of physical frailty is unknown, but it's believed to be related to dysregulation of metabolic processes, those metabolic processes that are related to energy production and energy expenditure. Index frailty, the second type of frailty, is also called deficit accumulation frailty. And it is based on the compounded effects or the cumulative effect or the additive effects of multiple underlying conditions, multiple underlying illnesses, in such a way that the more underlying conditions an individual has, or the more underlying conditions an older adult has, the greater the likelihood of developing index frailty. Again, the exact cause is unknown, but it is believed to be associated with the presence of multiple underlying medical problems. And this is important because there's evidence to suggest that specific underlying medical conditions such as heart failure, such as COPD and emphysema, such as certain forms of cancer, and even HIV disease, independently places the patient at an increased risk for developing frailty. So how do we diagnose frailty? What's the criteria for frailty? The Frailty tool, the Frailty assessment tool, is one of the main assessment tools used in diagnosing frailty. It's been validated by the Cardiovascular Health Study. Okay, and one advantage of this study is that it requires the participation of the patient. So the criteria to define frailty, basically any 3 of 5 characteristics would clinch the diagnosis. The first is weakness. Weakness as defined by decrease in hand grip strength. Weakness as defined by a decrease in skeletal muscle mass or sarcopenia, which tends to result in a decrease in strength. The second criteria is slowness, decreased motor performance. Third, decreased physical ability or physical activity. Fourth is self-report of exhaustion or decreased exercise tolerance. And 5% of weight loss over a 6 months to 1 year period. Okay, 5% or more of body mass decline. So any 3 of the previous 5 characteristics would clinch the diagnosis of frailty. So how would we manage frailty? First and foremost, it's important under the 4 M's framework to consider what matters to the patient, and therefore goals of care should be established with the patient and the patient's caregivers, the patient's family. Second, we ought to incorporate a multidisciplinary team-based approach. Okay, and the team would consist of everyone across the healthcare spectrum. This includes the primary care doctor, physical therapist, the psychiatrist, nurses, nurse practitioner, social worker, and again, the importance of the family and caregivers should not be overlooked. How do we manage frailty? Treat any underlying causes, any precipitating causes, any underlying medical problems. 4, minimize the number of prescribed medications. Take into account drug-drug interactions and the consequences of polypharmacy. So discontinue non-essential medications and perform periodic medication review in order to reduce the potential for drug-drug interactions and adverse health outcomes. 5, reduce or eliminate any kind of environmental risk or risk factors. Eliminate environmental stressors. 6, implement a fall prevention and a social support program. One of the main causes of frailty is undernutrition. Undernutrition can be addressed by providing access to food, providing adequate nutrition. Poor intake is often an indication of illness. Lack of access to food contributes to undernutrition, which in turn leads to unintended weight loss. Unintended weight loss, micronutrients deficiency, and vitamin deficiencies. Protein calorie supplementation is known, is proven to delay the progression of frailty and even reverse frailty. So provide proper nutrition, including protein calorie supplementation. Vitamin D supplementation can be beneficial. Vitamin D supplementation, especially in situations where the vitamin D level is low, the serum vitamin B12 is low. Low vitamin D level is associated with a higher prevalence of frailty at baseline. Therefore, vitamin D should be supplemented. Vitamin D supplementation may reduce the risk of falls, it may preserve muscle strength and improve balance. In terms of management of frailty, it is beneficial to implement a comprehensive exercise program that can be safely tolerated by the patient. What type of exercise? Muscle strengthening exercises, balance improvement exercises, balance training, and exercises that would improve exercise tolerance or stamina. There may be a role for, in situations where patients are unable to perform exercises independently, there may be a role for supervised exercise, physical therapy, and occupational therapy. So what are some of the benefits of exercise? The benefits of exercise include an improvement in bone mineral density, improvement in balance, improvement in strength, improvement in flexibility, and improvement in mobility, which in turn translate into improvement in functional status and an improvement in the individual's ability to perform activities of daily living. Additional benefits of exercise include a decreased risk of falls, and an increased sense of well-being. Let's transition to nutritional syndromes. Why is this relevant? It's relevant again because we practice evidence-based standard of care. So in evidence-based medicine, our assessments and our intervention should translate into an improvement in quality of life and life expectancy, or a decrease in morbidity and mortality. And again, this should be guided by the 4 M's in the 4 M's framework. What matters to the patient? So our goals of care should be aligned with the patient's will and the patient's wishes. Mentation, mobility, and medication. Whatever we do in terms of assessment and intervention should impact the patient's quality of life in such a way that it should translate into an improvement in the patient's ability to perform activities of daily living and or instrumental activities of daily living. This should translate into a decrease in disability, a decrease in dependency, and an improvement in the patient's ability to function independently. Why is this relevant? It's relevant because there are age-related changes in the older adult's body. Some age-related changes include changes in the body's composition in such a way that there's a decrease in bone mass, or a decrease in lean muscle mass, a decrease in skeletal muscle mass, and a decrease in the water content of the body. This decline in the water content, or this decline in the bone mass, or this decline in fat content, it all leads to a change in bioavailability, or it affects the bioavailability, and it affects the volume of distribution of vitamins and or minerals. And this has clinical implications. And it has clinical implications in such a way that standardized nutrient requirements for younger or middle-aged adults cannot and should not be generalized to older adults, and standardized prescribing habits that are used, or standardized prescribing protocols that are used in younger and middle-aged adults should not be generalized to the older adult patient. Why is this relevant? It's relevant because age-related changes in the body impacts energy expenditure, impacts energy requirements, okay? The basal metabolic rate, or BMR, also termed the resting energy expenditure, is the principal determinant of total energy expenditure in the body. So a decrease in the BMR reflects a loss of lean body mass, including skeletal muscle mass. Energy expenditure related to physical activity is variable, and again, it is not the principal determinant of total energy expenditure. How do we estimate energy needs? An estimation of energy needs is based on body weight, and it's not solely based on lean body mass. So in determination of energy needs, care must be taken to avoid overfeeding while meeting basal requirements. What are the nutritional requirements of the older adult's body? The older adult's body has nutritional requirements that serve to sustain life. It also serves to maintain or promote good health. These nutritional requirements can be divided into 3 categories: macronutrients, micronutrients, and fluid needs. Nutritional requirements are often explained in terms of a balanced diet or a modified food guide pyramid. Age-related changes in physiology, age-related changes in metabolism, and age-related changes in function can alter or change the older adult's requirements, nutritional requirements, in such a way, again, that standardized nutrient requirements for younger or middle-aged individuals should not be generalized to the older adult. In terms of abnormal nutritional intake, the term is malnutrition. Over a prolonged period of time, it's malnutrition. Malnutrition in older adults ranges from undernutrition to overnutrition, okay? This is important because age-related changes in physiology and age-related changes in metabolism and age-related changes in function can change the older adult's nutritional requirements. And again, this leads to malnutrition. Potentially, it can lead to malnutrition. How do we measure nutritional status? The term anthropometric is used. An anthropometric relates to the study of the measurements of size and or proportions of the human body. Body mass index, or BMI, is a measurement of the body size, and it's an indirect measurement of body fat content. And this is often used to assess nutritional status in older adults. How do we calculate the BMI? The BMI is calculated by dividing the weight in kilograms by the height in meters squared. Okay? Normal BMI ranges between 18.5 to 25 kilograms per meter squared. Inadequate nutritional intake or undernutrition is characterized by a BMI of less than 17.5 or even 17. A BMI less than 17 is associated with an increased risk of diseases, and it's associated with an increased risk of mortality. Okay? In terms of prevalence of undernutrition, as much as 13% of outpatient older adults are undernourished. Undernutrition exists in as much as 25 to 50% of hospitalized older adults, and as much as 50% of skilled nursing facility residents have a diagnosis of undernutrition. What's the definition of undernutrition? Inadequate nutrient intake is an average intake of food groups, nutrients, or energy 25 to 50% below a threshold level of the recommended dietary intake. Again, an average intake of food groups, an average intake of nutrients, or an average intake of energy that is 25 to 50% below a threshold level of the recommended dietary intake. That is inadequate nutritional intake. And also, energy intake that's less than 50% of the basal metabolic requirements, that is associated with a higher risk of death, and it's associated with a higher risk of certain diseases. Lack of access to food frequently or commonly contributes to undernutrition. It is important to determine whether poor access to food, whether limitations in resources and limitations in transportation and limitations in functional status limits access to food. Poor intake is often an indication of illnesses. Unintended weight loss of 10 pounds or 5% of the usual body weight in a 6 to 12 month period is an indicator of underlying morbidity. Poor intake, which leads to unintended weight loss, is a predictor of functional decline. It's also a predictor of increased healthcare expenditure, and it's a predictor of an increased risk of hospitalization. Undernutrition and poor intake leads to unintended weight loss. It can also lead to micronutrient and or vitamin deficiencies, which is associated with cognitive impairment, decrease in memory. It's associated with a decrease in functional status. It's associated with an increased risk of infections, increased risk of pressure injury, pressure sores, and poor wound healing. And it's also associated with an increased risk of mortality or death. How do we address or how do we treat undernutrition? First and foremost, education is important. Preventive measures are important. So education and preventive measures. Goals of care should be aligned with the patient's wishes, what matters to the patient. If poor access to food is the underlying issue, provide access to food. Title 3C of the Older Americans Act, Nutrition Services Program, provides for congregate and home-delivered meals for older adults, irrespective of ability to pay, irrespective of economic status. The Older Adults Act emphasizes that adequate access to nutritious and appetizing food should be assured for patients of various cultural backgrounds and in all settings, again, irrespective of economic status. How do we address the issue of undernutrition? 1, provide access to food. 2, enhance food intake. Measures can be taken to enhance food intake by 1, catering to food preferences. Attention should be paid to consistency of food, the color of food, the taste, the temperature. Food should also be culturally sensitive. The setting in which food is provided is also very important. Eating together may increase sociability and the likelihood of an older adult actually consuming the food. How do we address undernutrition? Treat underlying medical problems. Provide appropriate mouth and hand care. If dentures, dental pain, gingivitis, if oral care is necessary, provide oral care. Avoid therapeutic diets unless clinical benefit is evidence. Unless clinical benefit is evidence-based. avoid therapeutic diets. There's evidence to show that increased caloric intake addresses undernutrition. So a balanced diet, yes. Nutritional supplements may be beneficial also. High caloric density, lactose-free, gluten-free nutritional supplements. There's evidence to support the fact that nutritional supplements correlate with small but consistent weight gain in older adults. It also correlates with a decrease in mortality in undernourished older adults. Caution must be taken. Caution that supplement does not replace and therefore decrease the overall intake of food and essential vitamins and minerals intake. In terms of medication management of undernutrition, there's no evidence-based report suggesting that long-term survival benefit exists with medication. Caution must be taken when using periactin and or megas. Appetite stimulants such as cyproheptadine or periactin causes confusion in older adults. Megestrol increases body fat content without significant clinical benefit, and megestrol or megas is also known to increase the risk of DVTs, deep venous thrombosis, and pulmonary embolism. It also increases the risk of fluid retention and congestive heart failure. Let's transition to obesity. A BMI of 30 kilograms per meter squared defines obesity. A BMI of 35 kilograms per meter squared is associated with an increased risk of functional decline among older adults. Poor diet quality and micronutrient deficiencies are relatively common in older adults, especially older adult women living alone. Excess body weight and modest weight gain in middle age may be associated with medical problems later on in life. So excess body weight and modest weight gain in middle age is associated with an increased risk of developing hypertension, diabetes, increased risk of developing heart disease and strokes, increased risk of developing sleep apnea, and increased risk of developing osteoarthritis later on in life. Excess body weight is also associated with an increased risk of impaired functional status, increased risk of utilization of healthcare resources, and an increased risk of mortality. How do we address more obesity? How do we treat obesity? Education and encouragement is essential, and there's evidence to suggest that education and encouragement is more effective coming from a healthcare provider. In addressing obesity, care must be taken to reduce caloric intake. Okay, so a reduced calorie balanced diet is indicated. Regular physical activity also provides multiple significant health benefits for older adults. What is recommended? It's recommended to use moderate intensity aerobic physical activity or physical activity relative to ability. It's recommended to exercise 150 minutes per week, spread out throughout the week. That translates into approximately 30 minutes per day for at least 5 days per week. Muscle strengthening exercises, muscle strengthening physical activities at least 2 days a week is also shown to be beneficial. Thank you.